Good afternoon and welcome to the BREE Collaborative webinar on implicit bias and racial inequities in healthcare. And thank you for spending an hour with us to learn more about this extremely important topic. I am Amy Etzel, Implementation Manager with the BREE Collaborative. Before we begin, just a few housekeeping announcements. You all are on mute and will be throughout the webinar. Today's speakers and I would love your participation in a question and answer discussion after their presentations. If you have comments or questions, please type them in at any time to the Q&A box, and I'll use them to facilitate a session at the end. I will also try to check the chat box, but I will be looking primarily at the Q&A box. You can find that at the bottom of your screen. So we have some new people in our audience today from our previous webinar attendees, so I wanted to give just a very quick background on the BREE Collaborative itself and our guideline development process. We are a public-private group in Washington State formed by our state legislature in 2011. Our goal is to improve healthcare quality, outcomes, affordability, and equity throughout Washington State. Our collaborative members are appointed by our state governor and represent a variety of stakeholders in the healthcare landscape, representing health plans, public healthcare purchasers like our state Medicaid agency, and purchasers such as Boeing and SEIU 775, as well as representatives from delivery systems across the state and other quality improvement organizations. Every year, we select 4 or 5 healthcare topics with variation in delivery or outcomes that are used inappropriately or too often, that maybe are not used enough, or that have a patient safety equity issue that our community cannot address alone. As you can see, we have worked on a wide variety of topics. We try to select healthcare services annually that show inequitable utilization or that may be contributors to health disparities, such as higher rates of hysterectomies among certain populations. The BREE also just started work in September on a social determinants of health project that will include strategies to assess and address health disparities, including from racism within and outside of clinical care. And so within our work, as with all of your work in the past several months, we're really trying to be more thoughtful and explicit about how race and implicit bias informs and or limits our work. It's a topic that obviously needs more than a spotlight right now, and I'm really excited to learn with all of you over the next hour about the work our presenters are doing in this space. And so with that, I am going to stop sharing my screen and turn it over to our presenters so that they can grab the screen and set up their slides. Today, we are extremely lucky to have 2 researchers from the University of Washington working on the Unbiased study to share their new approach to address hidden healthcare issues by improving patient-doctor communication in primary care. Dr. Janice Sabin is a research associate professor with the University of Washington School of Medicine, Department of Biomedical Informatics and Medical Education. Dr. Sabin is affiliated faculty with the University of Washington School of Medicine for Health Equity, Diversity, and Inclusion. Dr. Sabin is one of the earliest investigators in the world to apply the science of implicit bias to healthcare disparities research. Her research includes examining a patient-provider communication in real-world clinic visits, healthcare providers' attitudes towards race, ethnicity, weight, age, sexual orientation, and the impact of implicit bias on healthcare. Dr. Andrea Hartzler received her BS in psychology and a PhD in biomedical informatics from the University of Washington. She was an assistant investigator at Kaiser Permanente Washington Health Research Institute before returning to UW as an associate professor. As co-director of clinical informatics and patient-centered technologies, a joint MS program between the UW School of Nursing and the Department of Biomedical Informatics and Medical Education, she oversees program development, curriculum, and teaches and advises students. Dr. Hartzler also serves in a leadership role operationally for UW Medicine to provide clinical informatics expertise and leads patient experience initiatives. She's served on multiple national committees for the Office of the National Coordinator for Health Information Technology, the American Medical Informatics Association, among others. All right, I will turn it over to our presenters. Thank you so much for being with us today.
Thank you so much, Amy. I'm hoping everyone can see the slides. Today I'm going to talk about implicit bias and racial inequities in healthcare. An overview of the talk today. is talking a little bit about social determinants of health, because health inequities lie within that framework. I'm going to talk about implicit bias. What is it? How does it manifest? A little bit about institutional climate, work environment, workforce diversity, strategies to address bias. And then our unbiased research project will be presented by Dr. Hartzler.
Janice, may I interrupt?
Yes.
We actually can't see your slides.
Uh-oh.
Yeah.
Oh dear. Okay.
We have a great view of you.
Yes, it is.
Okay. I will start over then. Sorry about that.
Are you able to grab the screen? It should, there it is.
So, are we there now?
Yes.
Thank you.
Thank you.
All right. So who knows what happened there? Gremlin. So I'm going to talk about a few common terms that, are thrown about, we hear about, but just so that, we are all on the same page with the definitions. So bias, which we hear a lot about, is just a positive or negative attitude towards people. A stereotype is a shared set of beliefs or a fixed impression of a group. Prejudice are negative attitudes and beliefs about what psychologists call the out-group versus the in-group. And that's me as the in-group and people like me and then everybody else. And then discrimination is the behavioral manifestation of these things. So you can have all those things operating, but they don't necessarily impact behavior, but can. Another term that we hear and that is also important is stigma. And that's the process by which certain human characteristics are labeled as undesirable and negative and linked to stereotypes about class of individuals, resulting in social distance from or discrimination towards these labeled groups. And then structural racism are these macro level systems, societal forces, institutions and ideologies and processes that all interact with one another and generate and reinforce inequities among racial and ethnic groups and other groups that are also stigmatized. Social determinants of health is a very broad theoretical framework to think about inequities. And thinking about social determinants, they run across all systems of society. So economic stability, thinking about neighborhood and physical environments in which people work and live, education, food, access to healthy options, people who do not have enough food, community and social context, so support systems, community engagement, discrimination and stress, and the healthcare system itself. So are people insured? Is there availability to services? Is there cultural competency, linguistic competency, and what is the quality of care? And this impacts health outcomes, mortality, morbidity, life expectancy. And thinking about this as when we think of healthcare outcomes, thinking of sort of multi-generational transmission of these conditions that can affect entire families for generations. Structural racism is social determinants of health that limit where people can live, for example. Residential segregation is pervasive in society, and it's symbolic of structural racism. Residential segregation impacts health, concentrates poverty. Environmental pollutants are more likely to be, to be exposed to in certain regions and certain areas where people live, and other adverse conditions that can all impact health. Residential segregation also is related to school and workplace segregation and immigration policies and limited services. So this is how society can be structured to be contributing to inequities. If you look at this was a study that was done recently at the University of Washington. These are two neighborhoods. And if you think about a healthy environment where people have access to services and clean air and parks, these are two areas. One is in University Place in Washington, and another is a neighborhood in the city of Tacoma. And they're about 4.5 miles apart. But as you can see from an aerial view, the lived experience of these two locations is quite different. The one on the left has much more green, and the one on the right, not so much. So that is kind of an overview of how residential segregation can impact health. I'm going to use infant mortality as an example of, inequities in healthcare and health outcomes. And, for anyone interested in disparities and health inequities, just look at the areas that you're interested in and look at the literature and find, whether or not there are disparities in certain areas and then some of the factors contributing. But I'm looking at the CIA data, the World Book, which is an interesting source for infant mortality data. And as you can see, if you look on the bottom far right, Monaco has 1.8 deaths per 1,000 live births in the first year of life. The United States does not fare that well. We are 5.8 deaths per live births in the first year of life. And as you can see, there's a constellation of countries that do better than we do on the metric. And again, this is CIA data. If you look at in the US by race and ethnicity, you can see there's quite a difference based on a person's race and ethnic background. So there are disparities in this area. And in our state, we rank 8th in positive with 4.7 deaths. However, we do have disparities based on race and ethnicity. Kaiser Family Foundation state sheet is also a wonderful resource. So I'm going to move into talking about bias. And again, this is positive or negative towards groups or people. And if you look at this was taken out of Louisiana, New Orleans newspapers during Katrina. And the one on the top, a person is shown in chest-deep water with supplies of some kind wading through. And it's described as a young man walking through chest-deep floodwater after looting a grocery store in New Orleans. Now on the bottom, there's another very similar photo. And this is described as two residents wading through chest-deep water after finding bread and soda from a local grocery store. And the people on the bottom appear to be white, and the person on the top appears to be African-American or a person of color. So this is sort of biased reporting, and how things are reported can really impact the general population's perspective of issues. I'm going to talk about implicit bias, what it is. It's also called hidden bias or unconscious bias. These are attitudes or stereotypes that affect our understanding, decision-making, and behavior without our ever even realizing it. So our mind works in several ways. We make first impressions very quickly, snap judgments. That's how we navigate our world. We have to decide, are we safe or not safe? We also make automatic associations, and these can be explicit or they can be implicit. We don't really know they're there. We absorb messages from our greater culture. When we think of automatic associations, just think of peanut butter and jelly. They kind of go together. Some people love peanut butter and pickle sandwiches, but that's not what comes to your mind first. And then in-group favoritism, as I mentioned before, just feeling more comfortable with people we perceive to be like ourselves. So you just looked at several unknown faces for a very, very brief time. And this was a study that looked at first impressions of a person and asked people to rank them as attractive, likable, competent, trustworthy, and aggressive, and found that they're made really quickly. Exposure to an unknown face for just 1/10 of a second was enough to judge these particular traits, and that's at the implicit level. The judgment didn't change with an increase of 1 second, but rather the person felt that they were sure their judgment was right with a little bit more time to look at it. So we make first impressions very quickly. It's just how our minds work. We have both implicit and explicit beliefs. Our explicit beliefs are attitudes and beliefs that we report to others that we know we have. It's our belief system. This is our rational level thinking, our higher level thinking. Implicit attitudes and beliefs are some of these automatic associations that are embedded, they're hidden, we're unaware they're there in our mind. We're exposed in our greater culture to these ideas, images, and beliefs. And this is our lower level thinking. So if you've ever come home after a busy day, opened your door with your keys, went inside, went about your putting your groceries down, taking the dog out, came back into the house, and then couldn't find your keys. I mean, that happens to people all the time. And a person who, is in that situation basically is using their lower level thinking as they're doing all that. They're opening the door, they're taking the dog out, they're putting their groceries down, but they don't really remember where they put their keys. They were sort of on automatic autopilot behavior, and that happens a lot. Implicit bias is common. It impacts behavior. It's contagious. It can contribute to microaggressions. It operates in the workplace, in patient care, and also at the policy level. There is a way to measure implicit bias. I don't know if anyone has done this, taking an implicit association test on the Harvard website, Project Implicit. And it's the most widely used indirect measure of implicit social cognition. And I use this measure in my research, but anyone can go to this site and take what's called an IAT. And people are asked to sort and pair images as they appear on a screen. And then if they associate, for example, a black face with good, and it's usually depicted by words, slower than associating a white face with the concept of good, then there's some kind of pro-white association going on. And bias operates in many, many areas. So in weight, ability, age, there are many different types of IATs that you can take and explore. Racial bias is also contagious. This was a study that looked at whether or not observing a biased person expressed subtle negative beliefs towards a Black person, and this was done in an experimental way, can shift our own racial bias. And they found that yes, it does. Just observing a biased interaction can make the observer have more bias themselves. The authors stated that basically biases creep into our minds and infect our behaviors without our ever knowing it. The good news of this study is that the flip side is also true. So observing and modeling positive behavior can shape society to be more egalitarian. And the take-home message from this is that we are all role models all the time. When implicit bias is more likely to impact behavior, particularly in a healthcare setting, for example, is when there's high cognitive load. So even if a person is, has an egalitarian belief system, they may show prejudiced behavior when there's clinical or other ambiguity functioning, situational uncertainty, just not really sure what to do, heavy workload, fatigue, and pressure of time. And that really, those last three qualities really define our healthcare system. So when there's cognitive load, people can sometimes operate automatically, and these unconscious biases can drive behavior. It's a very new field of study. The first study was in 2007. So 10 years later, this was a review article and found that 27 studies examined racial or ethnic bias. 10 other biases were investigated. So it's not just race and ethnicity, but gender, age, and weight. 35 and more. 35 articles found evidence of implicit bias in healthcare professionals. So we're just looking at whether or not professionals hold these types of biases. And all of the studies that looked at correlations related to behavior found that there was a significant positive relationship between the level of implicit bias and lower quality of care. The following year, there was another study, and that also found very similar. 37 studies qualified, and 31 found evidence of provider pro-white bias. And this was looking at racial bias. 14 studies looked at the association of implicit bias in healthcare outcomes. And interestingly, 8 found no association at all between the level of provider bias and the healthcare outcome. And 6 found that higher bias equaled disparities in treatment. And 7 of the studies looked at implicit bias in real-world care. Some of the others were experimental studies using case vignettes. And those found that stronger bias equaled poor patient-provider communication, which to me is really a clue on how to improve equity and looking at that clinical interaction and communication. So I'm going to move along to institutional climate and thinking about microaggressions. And this is a terrific book if anybody is interested in learning more about microaggressions. Defining microaggressions as brief and commonplace daily verbal, behavioral, and environmental indignities. It can be either intentional or non-intentional. And they communicate hostile, derogatory, negative racial, gender, sexual orientation, religious, and other types of slights that are experienced by a targeted person. An example of gender microaggressions, there's a concept of intellectual inferiority, that women are deficient in rational level thinking, like math and science. And so saying to a woman, "You articulate so well," that implies that it's a surprise. Another type of microaggression is the "you do not belong" microaggression. So a person being directed to the entrance for messengers rather than the main entrance of a building, just based on how they look. Another type of microaggression is being considered not trustworthy. So for example, people being monitored closely in stores based on their physical characteristics. And again, this is a great book if you want to learn more about microaggressions. Institutional climate, and this is a study that looked at university faculty and their perceptions of institutional climate. For underrepresented minority faculty reported difficulty in cross-cultural relationships, feeling isolated and invisible, having a lack of mentors and role models, experiencing overt and covert discrimination and feeling disrespected, an unfair burden of being identified with affirmative action, experiencing financial hardship. And so in your organization, what is the climate and how do people experience the climate of the organization? In the learning environment as well, this was a study that looked at 3,547 students from 49 US medical schools across the country, and looked at reporting racial climate and role models, as well as studying and gathering data on the medical students' implicit bias over time. So in IAT related to race in year 1 and in year 4. And these were self-identified white students. And they found that 49% reported hearing negative comments about African-American patients from attending physicians or residents. And those who are in that 49% who have experienced this, they found that this experience alone predicted an increase in their implicit racial bias in year 4. So again, coming back to that idea that we are all role models. So how do we address structural and individual biases? There's really no easy answer, and the research is young. But everyone has a role. So personally, become aware of personal bias using self-examination. Again, we're role models. Understanding we feel more comfortable and confident in people who share our own culture and beliefs. And so, for example, in the hiring process, when people are thinking of a good fit, is it really a good fit, or is it just because this person is like me? Positive and negative stereotypes can operate and influence perceptions of others. And then I think one of the most important ways to approach these topics is with extreme humility, understanding that none of us knows everything about this or is perfect, and wanting to continuously learn. This was a quote from a study that looked at homeless shelters, and the director of the homeless shelter said, "I mistook someone who was coming in for a job interview for somebody who was applying to the program, and I acted completely differently when I realized she was the person applying for a job than I did when I thought she was a candidate for the program." So that was a moment of self-awareness. Medical schools and healthcare systems must train everyone to identify and respond to structural racism when they see it. Education on giving people the language and tools to discuss structural racism and its adverse effects on patients and providers of color. Encouraging people to speak up and having systems for doing this, and then doing bystander training and employee education. Organizationally, collecting data, striving for equity, knowing when there are inequities, and monitoring that closely all the time. Examining policies and practices in a systematic way to see whether or not they may be contributing to disparities. Valuing diversity and increasing workforce diversity. The more diverse people at the table, the more likely solutions will be amenable to all. Reducing discretion in decision-making, having protocols in place and structured processes, and then developing a system of accountability. So why is diversity so important? This was a study that looked at, it was actually predicting stock prices, so it was in the business literature, and I didn't see it right away. But they asked individuals to compete in groups that were either homogenous, racial and ethnically, or diverse. And they found that in the diverse groups, answers to predicting stock prices were 58% more accurate than in the homogeneous groups. More time spent interacting in diverse groups yielded more accurate answers. And what the authors said is this diversity created a cognitive friction, disrupted conformity, equaled better critical thinking for all, and improved error detection, and produced these more accurate answers. And this was done in both Singapore and in Texas. So it wasn't specific to any type of diversity. It was just more diversity equaled better critical thinking and decision making. I'd just like to highlight this particular type of workplace discrimination, mainly because I have young women in my life who are having children, and I think it's sort of under-recognized that pregnant women and mothers actually are discriminated against in the workplace, and they're seen as less committed, they're steered away from prestigious assignments, slighted on bonuses, or considered less dependable, and, quote, more irrational. Another study found that each child takes away 4% of a mother's hourly wages, but adds an increase of 6% to a father's wages. So that's something to really think about. A study done at Stanford found what they labeled the motherhood penalty. Managers were twice as likely to hire a childless woman than a candidate with a child. So that's an example of workplace discrimination. There are many others, of course. So some practices to increase diversity in workplaces. One of the most promising, found in a very in-depth study called Searching for a Diverse Faculty at Berkeley, found that shaping a job description is highly important, and found that when a job was described to include issues of gender, race, ethnicity, and equity, they yielded more hiring of women and underrepresented in medicine faculty. So for example, instead of just saying they wanted the person to be an expert in labor history, if the job description said labor and women's history, this attracted a much more diverse applicant pool. Other promising ways to increase diversity of the workforce is intensive outreach, directly recruiting women and people of color and encouraging them to apply, prioritizing diversity. And then once there are finalists, having them come to campus or to your organization and meet with others and individuals from diverse backgrounds so they can get a sense of the climate in the organization. Also rewarding service and work on health equity and other types of equity and social justice. And the University of Washington, part of the faculty code says that a commitment to excellence, equity, contributions in scholarship, research, teaching, and service that address these commitments of diversity and equal opportunity may be included in the professional and scholarly qualifications for appointment and promotion. So this is a way for people to be recognized for the work they do in these areas, and also to attract people who are interested in an organization that values this. And in our state of Washington, these qualities must be gleaned from a CV or a resume because we are a non-affirmative action state. And so I'm going to turn it over to Dr. Hartzler now. And this, again, is research that's being done in implicit bias and understanding how to improve patient-provider communication. So I'm going to turn it over to Andrea now.
Great, thank you, Janice. So I'm going to share a project that is that I lead at the University of Washington, and am blessed to collaborate with Janice as a co-investigator on this project called Unbiased, which stands for Understanding Biased Patient-Provider Interaction and Supporting Enhanced Discourse. And this is a 5-year R01, which is a research grant that's funded by the National Library of Medicine at the National Institutes of Health. And next slide, please. I'm going to share this as one example of an individual level intervention to really get at self-awareness. And just wanted to begin by recognizing my team, who are just a bunch of rock stars and a good combination of information scientists, domain experts, computer scientists, both at the University of Washington as well as University of California, San Diego. It's a joint project between our universities. We have community champions. These are folks that are BIPOC people and LGBTQ people, which is the focus of our work. And so we're blessed to have community champions, domain experts that have expertise in human-computer interaction, patient-provider communication, nonverbal interpersonal communication, social signal processing, which I'll explain in a few slides, and clinical champions from both University of Washington and University of California, San Diego. Next slide, please. So the objective of this project, again, this is a 5-year project where we're focused more at that individual level of implicit bias as opposed to the more structural types of implicit biases that we know to exist. But our objective is to be able to use technology to be able to sense hidden bias in patient-provider communication. And we're doing that through a technology-mediated approach that's looking at audio and video to be able to look at nonverbal signals, things like eye contact, gestures, interruptions, so different forms of nonverbal signals that are associated with affiliation and rapport, or with, on the negative side, with control and dominance of conversations. So we're using a technological approach to be able to automatically assess those using artificial intelligence, machine learning. And then what we want to do is to then be able to provide reflective feedback to healthcare providers that helps raise awareness of when the conversation hasn't been going so well, as an opportunity to improve their communication skills. And so bringing kind of these two pieces together, this signal processing of communication cues with the design of reflective feedback, we hope our goal really is to make these hidden biases more visible so that people can raise their awareness and work to improve communication. Next slide, please. So I want to talk in a little bit more detail about our first goal, which is to automatically sense hidden bias in patient-provider communication. And we're really looking at primary care visits between patients and providers that have some relationship, so that they've at least had a few. It's not a new visit. It's a patient and provider that have known each other and are interacting in a primary care setting. And what we do is using things like body tracking through the Connect, bidirectional microphones, as well as eye tracking technology, as well as just traditional video signals and audio. What we do is record those interactions between patients and providers, and we look to see, look for particular kinds of nonverbal communication cues that through the literature have been associated with patient-centered communication. So we look at things like pitch or vocal back channeling. So for example, if someone's listening intently, they might say, aha, yeah, and they might nod their head as a sign that yes, they're here, that provider is hearing you as a patient. They might use touch. They may lean forward to suggest that they're really listening and they care about what the patient has to say. Again, eye contact, mutual gaze are signs that the communication is going well. There's also communication cues that suggest that things are not going so well. When there's a break in eye contact, when a provider might be paying more attention to their electronic health record than gazing and attending to the patient. When the provider interrupts the patient frequently and doesn't allow the patient to have the floor. So we're really exploring these kinds of nonverbal cues to see what can we learn about hidden bias. So if we were to have healthcare providers, for example, take the IAT. This is the test that Janice described that measures someone's level of, say, biased racial attitudes. And everybody has these to some extent. But if we were able to measure that through the IAT with a provider and then observe multiple interactions with multiple patients, could we automatically discern some differences in their communication patterns with different patients that have different characteristics? And so that's one of the areas that we're working on that's really exciting and innovative and quite exploratory as a new way to be able to understand implicit bias by observing it. Next slide, please. Thank you. So another component of this project is using an approach called human-centered design. And what this is really the goal here is to be able to say, if we can model these communication cues automatically through that social signal processing approach that I just described, through that technical approach, can we then design feedback that helps relay back to providers, here are times in the conversation that didn't seem to go so well. Here are some suggestions for how you might work on your communication and try some new things. And really the goal here is to engage both patients and providers through a human-centered design process to inform that feedback. So again, as Janice mentioned, Janice knows a lot about implicit bias, which is wonderful. I know quite a bit about human-centered design and informatics, but we really need providers and patients to partner with to have them really drive the design of what kind of feedback is going to be most useful to them. And so we are using human-centered design, a process to design this feedback. We're engaging BIPOC people as well as LGBTQ people. These groups we know experience implicit bias at higher rates than other groups, and so we're really starting with folks with expertise in those experiences to help us better understand what is that experience like within the clinic visit. We're also engaging primary care providers as well as patient navigators who observed a lot of patient-provider interactions as well to really understand what are the needs and interests in terms of feedback. Should the feedback be given in real time during a visit? Should it be given after a visit? Should there be some component of the intervention that happens before the visit. So we're doing that, which is called a needs assessment, and we're right in the midst of doing interviews with those patients and providers right now, and really hearing some very powerful stories that are providing some new insights into that experience, that real experience of implicit bias, or when the conversation hasn't gone so well. What is that like? The next step that we're going to do then is called co-design, where we're going to invite patients and providers to design prototypes or example feedback that will work over time, and make sure that that feedback is designed to meet the needs of patients and providers. We'll then go on to test those prototypes, and we'll be doing this in an iterative fashion so that we can refine and improve the prototypes, and end up with a design that is going to really be useful and meet the needs of patients and providers. So that's our second goal, human-centered design of that feedback. Next slide, please. And finally, what we'll do later on in our grant, we're in our second year of the 5-year grant. So when we get a little further along, what we're going to do is bring together the signal processing, that automated assessment, along with the feedback from that assessment, and then test it out to look at its efficacy to raise awareness of hidden bias in healthcare providers. We're going to do this first by testing in a lab setting with standardized patients, or patients that are acting, or patient actors. This is going to allow us to try to use different, really try to promote different levels of bias and see if our tool can pick that up in providers' behavior. So it's more of kind of a systematic evaluation, sensitivity of the tool. And then after that, we plan to do a limited clinical deployment where we partner with a clinic or two and try this tool out for a few weeks and see really what's the feasibility of implementing this. How do people feel about it? Is it useful? What are some of the barriers? So next slide, please. So that's that is our project. Again, I think it's very innovative. There aren't any tools out there to do this automatically. Largely, raising awareness of bias hidden bias in healthcare is largely something that you read in a book. There are limited opportunities to be able to practice this in real time. There are things like standardized patients, but there's not an automated technology that can help add to the pool of resources. So we really hope that we can not only learn more about hidden bias from the experiences and needs of patients and providers, but also to get some practical insights for how we might enhance training opportunities for healthcare providers as well as patients. And ultimately, we really hope that tools like this can help address healthcare disparities and improve the equity of healthcare. Next slide, please. That may be the last one. So yeah, so that's the last slide that I had on this project. I wanted to thank you very much from Janice and I for your attention today, and I think we can open it up to questions.
Great, thank you both so much. What a large project, such an important project, especially in these times that we're living through. So I'm really excited to see how this progresses. We have had a few questions come in. We'll start with a little bit of a political one. Are you worried about the recent executive action by the president and the administration harnessing your ability to train people, particularly related to structural racism? Can we go there?
Okay. Yes, of course.
Yes.
And I am just sort of thinking this too will pass. And so, I'm just focusing on research and dissemination of research, and, the climate in which we live hopefully will improve as far as these types of trainings and education.
Absolutely. Anything to add, Andrea?
I would agree. It doesn't change my mind about the importance of this. I think we
Sure.
still need to be moving forward.
If anything,
I'm hopeful for that. I'm hopeful for change.
absolutely. If anything, I think it highlights the importance of this work and digging into it further. Next question is, what role could health plans play in looking to find and intervene around implicit bias in clinical care? Have you engaged at all with plans, or are you primarily focusing in on providers?
Well, with the Unbiased project, we are that is outside of the scope of the plan projects. We have not engaged with health plans. It's an interesting idea, and I wonder, Janice, if you've done prior work at that, looking at that angle.
I have not worked with health plans. And I think that that's, really a fantastic opportunity, because I believe that, it's so important to, look at access, look at policies that limit or encourage people to seek preventive care and, head off really, catastrophic illnesses perhaps. And I think that, as I said, for organizations, it's very important to collect data and to monitor inequities and to monitor who is or who is not included. And so I think health plans can play a really big role in this. And I think that I'm sure that organizations are doing these types of trainings and, thinking about inclusion and diversity of the workforce. So all those things kind of converge together. And so I think that health plans can play a big role.
Yeah, I think about the way that it would be very hard, but taking some of your findings and trying to build in a way to incentivize more diversity and inclusion and some of all of that. It's a whole nother study that you can apply for after you're done with this one.
I'll just add, there's a lot of data. There's out there in the electronic health record and other systems that we just need to describe what's happening. What are the patterns? And looking at that through the lens of equity, I think we can learn a lot from the patterns and the data we already have.
Absolutely. What would it look like? Next question is, what would this look like for a provider that is working with a tribal community? I know just from my work that I've done that tribal communities are severely underrepresented in data and in studies and inclusion. And so I'm wondering, based on this question, have you had a lot of tribal representation so far with your work?
In our project? So I guess we can, because that's a really great question, and it's something that we thought really clearly about, actually having that as a focus. In the Pacific Northwest, we have a real opportunity to engage these groups, and we thought, wow, that would be great in a future grant. Some of the complexities of what we're looking at are cultural differences in communication patterns that so that may be a little bit different. So in terms of the computational piece, there may be some, we'd probably, I would imagine, use the same approach, but the actual modeling may differ a little bit if there's different practices, different cultural practices around healthcare visits. But I think if it were me that got to do that, I would take a very similar approach, having it be very, what we call kind of human-centered, and having that, really having a partnership with these groups to be able to have that input to drive the technology. But I think it's a really important area that an approach like this could be applied.
Sure.
So I'll just chime in also, kind of on the other end. I've done work with tribal communities and, done it under the framework of community participatory research, so that, all the types of interventions that we wanted to work on related to Native health, having the community inform us on how that would look. And I think that that's one way to kind of mitigate the impact of implicit bias in working with Native communities, rather than coming in on, I know everything about everything. So here's what we need to do, is taking a much more community-based, participatory perspective. And I worked on a study where we actually had tribal college students in several tribal college settings help us design health information. So culturally tailored health information is incredibly important. And we had local artists kind of donating images and, putting together flyers. This was all about signing up for the organ donation registry. And it worked really beautifully to have the community design their own health materials. And I think that that can be a way to help mitigate bias that is experienced by individuals when everything around them speaks about their community and was designed by their community. And I would never presume to know what the issues are. So really having people help us understand what the issues are. And I think, again, it's an area that deserves a lot of attention.
Absolutely. And having marginalized communities feel a sense of empowerment and development process can be so important and go such a long way. Okay, we're having more and more questions come in. This is exciting. Let's see. Mental health disparity is a huge problem. BIPOC individuals have less access to psychotherapy. Is this an area that you have considered exploring? I know you've been focusing on primary care so far.
Yeah, we're starting with primary care, but definitely other areas of healthcare are of interest, in the future. We are looking at HIV care, with our LGBTQ plus population, but have been fairly focused on primary care. But thank you for that. It's important that that we think about that. That individuals intersect with the healthcare system in a variety of ways, and so kind of for this project, we're fairly focused because we can't take it all on. But
no, it's understandable. Mm-hmm.
Definitely a great idea for future.
Sure.
Yeah.
Anything to add, Janice?
Well, I did a study that looked at frontline mental health providers, and this was sort of back a while, and looking at whether or not providers have implicit bias, and we were looking at whether they were biased more towards physical illness as curable than mental illness as curable, because the public health mental health system embraces the concept of recovery, and we found overall among this sample they did not differentiate between physical and mental illness, but for the ones that did and favored physical illness as being more curable than mental illness, so having doubts about recovery basically implicitly, we found that these providers had less positive degree of clinical competencies. So they were less clinically competent. So again, that's a point of potential intervention. And that's kind of what research helps to identify, or points of intervention. So if these people were less clinically competent, let's increase people's clinical competencies so that they can embrace the concept of recovery.
Sure. Okay, a timely question for the world we're living in now. Have you done any research on bias between providers and patients in a virtual environment with telehealth and/or video visits?
We are hoping to, and it is very timely, because we're seeing at the University of Washington and elsewhere, we're seeing disparities, right? And who has access, they're really accentuated. So what better time to explore this? I have had some so we've been actively looking for partners, clinics to partner with, clinicians to partner with who might be open to having their visits recorded for research purposes. And through some initial conversations, I've had some really interesting discussions with providers who are offering telehealth at kind of the new view that they get of the patient by having kind of a window into their home and other people, and some of the things that I've heard were quite surprising. I'm not a healthcare provider myself, but there are some concerns about just having that new view of someone outside of the clinic, and that actually being a new source of implicit bias, right? So you see someone's calling from a homeless shelter, and maybe you didn't know that they were homeless, and does that add a layer of additional kind of stereotypes on the care you're providing? I thought, wow, that was quite interesting. But I think there's great opportunities, especially now with telehealth, to be learning how to, even if it's just communication, how do we improve patient-centered communication in this new virtual world that we're all living?
Yeah.
Yes, very interested, and we're trying to do that.
Sure.
And looking for partners.
Anything to add there, Janice, before we move on? Okay.
Yeah.
Do the providers know they are being studied, and or when the actor patients come into the room? Like, I had a question about that as you were speaking. To what level are the providers aware of what's going on? Or are they willing participants?
Yes. So this is a research that has gone through, ethical review through an institutional review board, and so it's not a quality improvement initiative. It's a research project, and so every participant goes through a process called informed consent, where they are provided with information about the procedures that they go through. So we've got to do that. It's really important for ethical research, and so that's going to limit our ability to really, kind of turn the knob. But I think we can still present them with standardized patients that look different. We'll understand some of the biases that these providers are coming into the room with naturally by having them take tests like the IAT. And we may be able to set up a situation through a scenario or a vignette with the standardized patient to see if we can bring out some of those implicit behaviors. We may not be successful, but that's how we're going about it. And I don't know, Janice, you've had a lot more experience with standardized patients. Do you have some thoughts on that?
No, not really on standardized patients, but I will say that the research that's been done, mine and I assume others, has all gone through IRB review. And when I do a study and I ask providers to, a part of the study, take an implicit association test, and I've done this many, many times, many different types of IATs, it's described as a cognitive test that looks at bias. What I find, again, Andrea sort of alluded to this, people who choose to participate in the study after informed consent are people who really care about this topic and are willing to do this. And so what I think is that the research really underestimates the type of bias that is actually out there, because how many people are, willing to kind of put themselves out there and do this? And I would tend to think the most biased people are not interested in these types of studies or this type of research or going to Project Implicit. So, that's interesting, but people often really want to contribute. And so I've found that, it's being upfront with what it's about is extremely important.
Absolutely.
And I think we'll still learn a lot, even if we've got some Hawthorne effect, or we're not capturing everybody in a representative sample, kind of as a first step to trying out. And really, it's more of a developmental research project. I think we're going to learn a ton, especially with people who are interested and have given this some thought, and might have some wonderful ideas to guide our work.
Absolutely. Well, I want to be cognizant of everyone's time. We have 1 minute left, and so I just want to say thank you again to our presenters. I apologize to those questions that were unable to be answered, but the contact information will be emailed out later this week, along with our slides and a recording of today's webinar. So, feel free to continue the conversation. I did just want to put in a plug. The BRIE Collaborative does have a mailing list, and so that link will be emailed out with our slides, and future webinar announcements will be emailed out at that time. I will be participating. The BRIE Collaborative webinars are shifting a little bit next month. I'm participating in a webinar with the Washington State Medical Association around our LGBTQ healthcare guidelines. And so a link to register for that webinar happening next Friday will be in the slides as well. And I just thank you all for your time today and being part of this conversation. Thanks, everybody. I hope you have a wonderful day.
Thank you.
Thank you.
Bye.
Bye.